is associated with your liver, your gallbladder, and your pancreas. So these are the three big endocrine organs of digestion. Exocrine organs, I take that back. Exocrine. Anything that's secreted into the GI tract, exocrine. So this is one time where understanding a little bit of anatomy is really important. So if you look, you have the liver, you have the gallbladder. The definition of a bladder is a hollow muscular organ. So the gallbladder is a hollow muscular organ. And then you have the pancreas. And just real quick, some of the anatomy. You got the head of the pancreas, then you have the body, and you have the tail of the pancreas. The pancreas has both endocrine and exocrine functions. So the endocrine portion of it, it's going to release insulin and glucagon in terms of maintaining blood sugar, but it's also intimately involved in digestion because it will release digestive enzymes, pancreatic amylase, which digests carbs, pancreatic lipase, which digests fat, trypsin, and chymotrypsin that digest protein, and then nucleases that digest DNA. It also, as you learned in the little video that I talked to you about digestion, it releases bicarbonate. And the purpose of the bicarbonate is to neutralize that acidic chyme that's coming from the stomach. The enzymes of the small intestines and the pancreas work optimally at a pH of about 5 to 6, so a much more neutral pH as opposed to the stomach where the pH is closer to 1, 1.5, 2, very acidic. So let's talk about this. First of all, one of the things you have to know is how you make bile. Bile is made in the liver, but it is stored in the gallbladder. Oops. Gallbladder. Okay, so bile is produced in the liver, and then it's stored in the gallbladder, as I explained before. And where do you get bile from? You get it from dead red blood cells. So red blood cells live about 120 days, and they have a cell membrane, and most of the components of the red blood cell is hemoglobin. So when the red blood cell membrane ruptures, it's going to reveal the hemoglobin. And red blood cells, when they go to die, they can go to the liver, spleen, or a group of enzymes located in the capillaries called the reticuloendothelial complex. Basically, they destroy the red blood cell, they rupture the red blood cell, and they reveal the hemoglobin. Then the hemoglobin is then enzymatically broken down to heme and globin. Go figure, right? The globin, that's a medical term for protein. Those are amino acids chemically bound together. The liver takes that. We don't store a lot of amino acids in the liver, so it takes those proteins and either converts them to glucose or fat. The heme portion is the critical part. The heme portion is broken down to iron and bilirubin. And bilirubin has a yellowish green brown color. That bilirubin then goes to the liver and it's converted to bile. And bile is basically bilirubin from dead red blood cells, cholesterol, and bile salts. So basically what bile does is it's got a hydrophilic and a hydrophobic end. And basically what bile does is it helps emulsify fat. It takes big fat globs and breaks it into little fat globs. This is what allows the digestion of fat to occur better. Without bile, it's very difficult to digest fat completely. So bile is what's referred to as an emulsifier. So once that bile is produced in the liver, as you can see, the common hepatic duct and the cystic duct come together to form the common bile duct. And as you can also see, the pancreatic duct, which releases bicarbonate and digestive enzymes, meets the common bile duct at what's called the ampulla of Vater. And there's a little circular band of muscle called the sphincter of Oddi that prevents the contents from the pancreas, liver, and gallbladder from constantly dumping into the duodenum. So in some situations, and as you get older, you have what are called the 5 F's of gallbladder disease. The 5 F's of gallbladder, people who are at increased risk for the development of gallbladder disease are female, fat, over 40, fair skin, and fertile. Those are the 5 F's for gallbladder disease. So if someone's complaining of epigastric pain, typically half hour, 45 minutes, an hour after they've eaten something that's high in fat, and they have some of these things, some of the 5 F's, you always consider gallbladder disease. Now, with the gallbladder, one of the functions of the gallbladder is not only to store the bile, but it also dehydrates the bile. So the gallbladder will remove water from the bile, so that makes it a much more concentrated bile. So that tends, especially in females who tend to dump more cholesterol into their bile, cholesterol hard, right? It can form these stones or cholelithiasis. Now, watch. What's bile needed for? To emulsify fat. So if you eat a meal that's high in fat and that food enters the duodenum, right? That fatty meal, it's going to signal the gallbladder to contract and that sphincter of Oddi to relax. And you are going to send bile through the common bile duct into the duodenum to help emulsify that fat, to make that fat easier to digest. Break it up, big fat globs, little fat globs. Now, if you have stones in your gallbladder, when the gallbladder contracts, those stones can lodge in the cystic duct. And if you descend that, irritate that cystic duct, that will produce pain. So common signs and symptoms of gallbladder are typically epigastric pain or right upper quadrant pain that worsens after a meal, usually half hour, 45 minutes, hour after a meal. And you can get some nausea and vomiting and sweating, tachycardic. And if it's bad enough where this becomes inflamed, you can actually, get a fever. So those are the common signs and symptoms of gallbladder disease, and you should always think of that as being a potential cause, especially after someone has eaten a meal that's high in fat. So gallstones are called cholelithiasis. Inflammation of the gallbladder, and one of the causes of inflammation of the gallbladder can be gallstones. The treatment, typically, there's 2 basic treatments. One is extracorporeal sound wave lithotripsy, where they break up the stone and allow the stones to simply pass into the duodenum. Or they simply remove the gallbladder. And when you remove the gallbladder, what can happen over time is the cystic duct will actually hypertrophy and make a small gallbladder. So what physicians and nurses should be telling you is that, well, I don't know, for about 6 months after you had your gallbladder out, you should be watching the amount of fat in your diet, because it can make the digestion of fat a little more difficult, because even though the liver is releasing bile all the time, it's not as concentrated as it was when you had a gallbladder, because the gallbladder dehydrates it. So those are the common signs and symptoms. Right upper quadrant pain that can radiate to the back or the epigastric area. nausea, vomiting. Severe cases, you can get fever. And the most common cause of gallbladder disease is gallstones. Acute gallbladder attack is usually due to the stone lodging in the neck of the gallbladder and the cystic duct and producing pain. Once the stimulus for the gallbladder to contract, fatty food in your duodenum, is gone, that the pain should go away, it should dissipate. But if that stone is lodged in there, that pain may persist. So how do you diagnose gallbladder disease? Well, one of the ways you can is with a simple x-ray. X-ray is able to see if there are stones. Remember, x-rays, the more dense object is, the more x-rays it absorbs, so they'll show up as opaque on the x-ray. Now, the other way to do it is what's called a HIDA-scan. HIDA-scan stands for hepatobiliary immunodiacetic acid. Basically, what it does, it's a nuclear medicine test where they use a radioactive tracer. And that radioactive tracer binds to bile that's created in the liver. So what it's able to do is to see if the hepatic ducts, the cystic duct, and the common bile duct are all working properly. So with that tracer, what happens? The liver produces the bile, then it gets stored in the gallbladder. So if there is a problem with the gallbladder, let's say there's a gallstone, then you're not going to see any of that bile in the duodenum. You won't see any of the tracer either. And with that bile, you can't form anymore or store anymore in the gallbladder. It's going to start backing up into the liver and then start backing up into the tissues, and then it's eliminated in the urine. So that's what a HIDA-scan does. So X-ray, HIDA-scan, ultrasound too, because it picks up more denser objects. You'll be able to pick it up. That can be used to diagnose gallbladder disease. Okay, let's talk about the liver and some of the functions of the liver. It's really important to remember is that the liver detoxifies everything that you put into your pile. So everything that is digested and absorbed has to go through the liver first. And again, if you watched how I tried to explain the absorption of nutrients, glucose, amino acids, water, electrolytes, in the intestines, I explained to you that it was absorbed into the venous end of that villus. And what's important to note is this. All of the veins of the digestive tract in which nutrients are absorbed, they come together and they meet at what is called the hepatic portal vein. A portal circulation is where two capillary beds meet without having to go through the heart. So the liver has a portal circulation which allows veins, capillaries of venous blood and capillaries of arterial blood to meet without going through the heart. And this is important. So if you remember, all the nutrients of the digestive tract are absorbed into the venous end of that villus, and then all of those nutrients are transported to the liver for at least one function, detoxification of, like, alcohol or medication. or anything that, chemicals that are in your food. But if we also recall from our discussion of the circulatory system that there's no pressure in veins. So there's very little pressure in the portal vein. And because veins are thin-walled compared to arteries, if pressure is applied to them, they can pooch out. And if they rupture, then you can bleed. So I hope you're following where I'm trying to go with this. So watch. And this is again important. When an organ fails, in the case of the liver, all the functions of that organ fail. So in the case of a person who's going into liver failure, cirrhosis from drinking. Cirrhosis is basically just death and destruction of the liver. And typically you can destroy about 70% of your liver, but the liver has the ability to regenerate itself. But once you go past that 70%, it loses that ability, and you can't adequately, the liver can't adequately perform all its functions, and the result is that you go on a transplant list or you die. So let me just show you this real quick. So here you got the small intestines. Remember that the nutrients are absorbed from the venous end of the villus, and then all the veins meet at the portal vein and then dump their contents into the liver. And again, the liver will detoxify it, and then once the blood is detoxified and essentially cleaned, it leaves and then is dumped into the general circulation through the hepatic veins. The hepatic vein connects with the inferior vena cava and then dumped into the right side of the heart. The other thing that's important to note too is that the spleen is also connected to the portal vein. So when you get liver problems, you can get spleen problems, like an enlargement of your spleen. So let's talk about that first. And again, one more time, when an organ fails, all the functions of that organ fail. So one of the big functions of the liver is to take all the blood from your GI tract, or the vast majority of it, bring it to the liver where it's filtered, cleansed, right, detoxified, and then it leaves the liver and then joins the general circulation through the hepatic vein. And again, very little pressure in the portal circulation. So in a person who has liver failure, all the functions of that organ are going to fail. Now, watch. If the liver you have cirrhosis of the liver, damage to the liver, so this is all gone. It's not doing its function anymore. The same amount of blood is going to try to come back to the liver. But if the liver is damaged, right, you're going into liver failure, you cannot bring all that blood back. It will start building up in the liver, and then that blood is going to back up from where it came from. And where it came from was the venous system of your GI tract. And because veins have thin walls, they're not used to a lot of pressure, they will balloon out. Those veins will balloon. And you get what are called varices. You get esophageal varices, right? Or basically hemorrhoids in your esophagus. And hemorrhoids are weakened, ballooned out veins. Or you'll end up with hemorrhoids. If you also recall, one of the functions of the liver is to store vitamin K. Vitamin K is fat soluble, and vitamin K is involved in the extrinsic pathway, blood clotting pathway, to cause blood to clot. Well, if you don't have a lot of vitamin K, you can't activate the clotting factors of the extrinsic pathway, and you can't stop bleeding. So your rupture these hemorrhoids or you rupture these esophageal varices, and you compound that with the inability to clot your blood, you bleed to death. So that's why people who have liver damage or going into liver failure, one of the ways they die is GI bleed. Now, I'm going to do a little chemistry here. I don't like it. Okay, so again, remember, when an organ fails, all the functions of that organ fail. So when a person who is in liver failure eats protein, it will get digested by their digestive tract, and then the amino acids, as you recall, contain this little nitrogen-based compound called the amino group. Those amino acids go to the liver. And when they go to the liver, that amino group gets hacked off. And in the liver, it's converted to this stuff called ammonia. Ammonia is bad for you, toxic. So the liver takes it and converts it to a more water-soluble, less toxic chemical called urea. And how do you get rid of it? You get rid of it by peeing it out. So blood urea nitrogen is where you get rid of blood urea nitrogen through the kidneys. So if a person has liver failure, you don't want them eating a lot of protein, because that will cause the ammonia in their blood to build up because they can't convert it to urea fast enough. Now, this is the other way that people with liver failure die. Remember that you have the blood, and then you have the cerebral spinal fluid, and then you have the brain. So this is a brain cell. And there's stuff in the brain cell, and there's stuff in the blood. So the osmolarity of the blood and the brain, they have to be the same. And remember, if stuff can't move, water can always move. So one of the things that happens is in liver failure is you start building up in the blood, you start building up ammonia. Now ammonia can freely leave the blood, go through the cerebral spinal fluid, and enter the brain. So what you will do is you will increase the osmolarity within the brain cells, and that is going to cause fluid to shift, and it will cause the person's brain to begin to swell. The brain doesn't have a lymphatic system. The central nervous system doesn't have a lymphatic system to drain off that extra fluid, so that brain will begin to swell and will begin to compress blood vessels, and those people will begin to lose consciousness. That's called hepatic encephalopathy, and they go into a hepatic coma and die. However, one of the treatments, and it's not a curative treatment, it's palliative, meaning that it just kind of helps the person out, is you got ammonia in the blood here, so they will give them this stuff called lactulose. Lactulose is basically fiber, and it will cause the ammonia. They'll give it to them, orally, and because the lactulose, right, is in the large intestines, it will osmotically draw out the ammonia from the blood, and then the person will crap it out. So that kind of helps explain a little bit about some of the big problems that people with liver problems have. So let's look at the questions here. Why do patients with liver failure develop jaundice and ascites? Well, ascites, I covered that like week number 1, so you can review that. And why do patients with liver failure develop GI bleed? I explained that. So now what I'm going to do is go over the pathophysiology of pancreatitis. Now, remember that the pancreas is involved in digestion as well. And again, if you look, and then that's why knowing just a little bit of anatomy would really, really help you out. So if you knew the fact that the gallbladder, the liver, and the pancreas were kind of connected together, and they all come together at what's called the ampulla vater. You got that little sphincter Bodhi there. I reviewed that with you in that little video I put together for you. But basically what happens is this, is the pancreas releases digestive enzymes, amylase, lipase, right? Then the purpose of that is to get it into the pancreatic duct and then deliver it into the duodenum where your food is. Well, one of the most common causes of acute pancreatitis is gallstone obstruction of the sphincter of Bodhi. So what happens is that the person who's about to develop pancreatitis, they eat some food, right? So they got some food here in the duodenum. That signals the gallbladder to contract and try to get some bile in there. And it also signals the pancreas to release its digestive enzymes. Here's the thing though, you got to get those digestive enzymes into the duodenum to digest your food, but you got a gallstone being obstructing that sphincter of Bodhi. So what happens is this, is those digestive enzymes stay within the pancreatic duct and they do their job. They begin to digest fats, carbs, and protein. So what happens is you begin to digest your pancreas. That is acute pancreatitis. And the most common cause of acute pancreatitis is the blockage of the sphincter of Bodhi by a gallstone. So what caused the digestive enzymes to be released? Well, food in the duodenum. So if someone has pancreatitis, do you want the pancreas to continue to release digestive enzymes? Good. That's an excellent answer. Of course you don't. So what you have to do is you have to make sure that this person does not eat. Not only can they not eat, but even stomach contents, hydrochloric acid secretions can precipitate and stimulate the release of digestive enzymes for your gallbladder. So that's why you got to stick an NG down them and put that to suction and suck out all their stomach contents as well. Then you have to give them IV fluids. You give them some pain medicine, right? And you say a prayer and you hope that they don't go septic or die or bleed to death. So the signs and symptoms associated with acute pancreatitis are sudden onset of severe epigastric or abdominal pain, bloating as you get inflammation from the destruction of the pancreas. In some cases, you will get what's called a Cullen sign, or you will get a hemorrhagic circle around their belly button. They can go into shock from this, and they can also go into hypovolemic shock or hemorrhagic shock, and then later can go into septic shock as the pancreatic enzymes begin to digest the pancreas and then cause stuff from the duodenum to begin to leak into the abdominal wall. Now, how do you diagnose pancreatitis? Well, a lot of it is based on how they present clinically, their signs and symptoms. The labs you can draw, and again, watch if this is a pancreatic cell. digestive enzymes. If you release the amylase and lipase, and then they started digesting the pancreatic cells, all the amylase and lipase that used to be stored in healthy pancreatic cells will now enter the blood. That's pretty much the gold standard for assessing pancreatitis. You also look at C-reactive protein. It looks at inflammation. So if you have amylase, lipase elevated, and their C-reactive proteins elevated, yeah, that's a pretty good sign they got pancreatitis. Now, one of the things that pancreatitis can produce, and I'm just going to mention this, is hypocalcemia. And how it produces hypocalcemia is that when you release lipase into the blood, lipase digests triglyceride, and it will digest it to glycerol, and then these things that are hanging off of it are 3 fatty acids. We talked about this. And what happens is these fatty acids that are digested by lipase have a negative charge. Floating in your blood is calcium with a +2 charge. So they combine there, and that lowers the amount of free-floating calcium in the blood. So that's why pancreatitis causes hypocalcemia. Okay, ERCP. ERCP stands for retrograde, endoscopic retrograde pancreatography. Basically, what it does is you snake a tube down there, mouth, nose, through the stomach, pyloric sphincter, into the duodenum. You put it into the sphincter vodi. You dilate the sphincter vodi muscle. There's a little claw in there, and if there's a stone block in it, you pull it out. Problem is sphincter vodi don't like that, and sometimes the sphincter vodi can clamp down even harder and cause the pancreatitis to worsen. So an ERCP can actually cause pancreatitis. Right. Okay, the remainder, 22, 23, 24, and 25, you guys can look up. I'll make you open that book. All right, and then I'll see you on Tuesday, 25, multiple guest questions from the stuff that we talked about, and just some basic questions on Crohn and colitis. Right, you can look that up in your book, that book.